one of these flashlights, right? Okay? What you want is one of these flashlights.
Which there's a bunch on your table.
So you see the difference. Okay? So if you've got one of these, throw it away. Use one of these, and when it gets to look like this, throw it away and ask Nicole for another one.
I have boxes of them.
Seriously, throw this away, because it's worthless. The reason it's worthless is because if you're going to stimulate somebody's pupil, you have to throw enough photons onto the retina to get an adequate stimulation, and that won't do it. So the cranial nerve exam, and I usually have a little stool for this, so you want to stare at somebody, and usually this gives you the opportunity to touch somebody. I usually hold them by the chin, just gently, just so they know that they're not supposed to move their head. And then just with a finger, you just say, follow my finger with your eyes. Now, buddy up and do this with somebody. And I'll show you the trick. Now, buddy up, stare at your buddy's eyes. Okay?
Jana?
Stare at their eyes. You stare at their eyes, and you'll notice that there's little reflections of light on their corneas. You see them? They're going to be different in everybody because you've got lights in different orientation, but the location of that reflection next to the pupil, next to the iris, should be the same on both eyes. Go ahead, don't look at me, look at her. Look at her eyes. Look at where the light reflects on her cornea. You see? You see the little white dots? They should be in the same spot on the left eye and the right eye. Yeah, let's turn the lights up a little bit more. You see what I'm talking about?
Right. Yeah, I'm just like,
So now, while you're holding on to your partner's chin, and you're staring into his or her eyes, and you're identifying where those little reflection dots of lights are on their cornea, now say, follow my finger with your eyes. Come on, do
all
it.
right. Follow my finger.
Okay, and
With your eyes
don't be wiggling around so fast that they can't see anything. Hey, come on, pay attention. So don't be wiggling around so fast that they can't follow you. You want to say, follow my finger with your eyes over here. Now, you're going to ask them, do you see one or two? But while you're asking them, you're staring at them to see where these reflections are in relation to their pupil and their cornea. Okay? If their eyes look like geckos, okay, the reflections are going to be in different spots on each eye, and you'll be able to key in on it. All right, so you basically want to left, right, up, down, and for bonus points, you can have them accommodate, which means follow my finger as it comes in, okay, and their eyes should come in like this. So that's extra points for that. So now, you just tested 3, 4, and 6. And all you want to know is this normal or is this not normal? Simple as that. Then, while you're there, you can also test visual fields, and the easiest way to do that, assuming that you have a normal visual field, okay? Tell them, cover up one eye. Don't tell them to squint, just cover up an eye, because if you squint, then there's some physiology there that you don't want to mess with. Just cover up one eye and stare at, so she covers this eye, you cover this eye.
Okay.
She stares at my pupil. Okay, so now we've got this line between the two of us. And you say, can you see these? Assuming my eyes are normal, she'll see them the same time I see them. Okay, so you start out here, you say, when can you see this? Yep, here, 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 here. And the most typical visual field defect you'll get is in someone with a pituitary tumor, which is putting pressure on the optic chiasm from below, and you get a very classic, what's called a bitemporal or bilateral, outside lateral temporal field cuts, and you'll go like this, and she'll say, now. I can see it up here, she can see it here, so that's what we call a field cut. And the way that we describe it is, the way that fields are described classically are from the examiner's point of view. So, at least in my notes, you'll see 2 big circles, and then I'll take the field cut and hash it out. But those two circles are what she sees looking at me. And so because that's really confusing, most people will also label them which is left and which is right. But it's in reference to what I see the patient doing. Okay, so that's 2, 3, 4, and 6. Okay? So next you want to look at 5. And basically, you push their hair off their forehead and just very lightly touch both sides. Does this feel the same on both sides? It's hard on the forehead because there's bone underneath it. It'll be easier if you touch your hands together. That way you can make sure that the pressure you're exerting on the forehead is the same. Does this feel the same on both sides? This here, okay? Now you want to go to facial motor, and you say, wrinkle up your forehead. No, or squeeze your eyes tightly closed, and you try and elevate them up. So that's upper face, and then you can just say, this is, so now you do muscle here. You've already done sensation. Your hands are close to her face already. You might as well say, can you hear this? Can you hear this? Most people, even older people with decreased hearing, are going to be able to hear the sound of dry fingers rubbing on one another. If they can't, that's a significant hearing loss. If they can't hear this, then click your fingernails. You guys can almost hear this from here. Okay, so that's a down and dirty. And then if they've got hearing loss, what you want to know is, do they have functional hearing in that ear? And the test of that is, can you carry on a telephone conversation with that ear? If you can, then you have what we call greater than 50% speech discrimination. If you can't, that ear is worthless to you. And then, so now the upfront in your face stuff is over with. Now you can reel back a little bit, say smile. Now everybody's, at least my patients, are always kind of awkward about smiling, because most of them have got yucky teeth. And so mimic, say smile and show me all your teeth, and you do it too, like this, okay? And what you want to do is you want to look for symmetry at the nasolabial folds here, at the edges of here, and you want to look at symmetry in her, platysmal muscle. Beautiful, perfect, symmetric face. While they're used to having their mouth open like that, now you say, stick your tongue out, wiggle it left and right, and people are hesitant to do that, so you do it too. You say, go like this. Okay? And that's the cranial nerve exam. You've got 2 visual fields, 3, 4, and 6, eyes left, right, up, and down. You got motor sensory. Does this feel the same? You got facial sensory, you've got facial motor, moving and smiling. You've got auditory. You've got 12th nerve function, and you notice 9 and 10 we don't test. It's not part of my, do you normally test 9 and 10?
Sometimes, not always.
Yeah, you don't get points taken off for not testing those. And then you can do the spinal accessory nerve, which is SCM, sternocleidomastoid musculature. These here, by saying push into my hand, or shrug your shoulders, because it does trapezius and SCM. Okay, so any questions on the cranial? So what you want to do is, again, touch your patient, get them used to touching you. Now you don't want to be screwing around a lot here, and so what I've done is do the exam kind of out of order, just for patient convenience. Grab somebody like this. It's a good way to control somebody's arm, and put them all the way into a supinated post that isolates the bicep. You just say pull. Okay? This is C5. Let go and say push me away. Now, if you hold on, to isolate the tricep, you want complete supinated or anterior rotation, whatever this is called. And it's tough to do while you're holding on to them, and patients don't really get it. They'll start pushing like this or pushing like this. So I usually let go of them and I put my hand up like a stop sign and say, push me away. This automatically isolates the tricep, which is C7. While you're there, now say, lift your wrist up and don't let me push it down. Come on, okay? This is ECR or C6. So what I do is I go pull, 5, push me away, 6, do it on the other side, 5, push me away, 6. Now, with both hands, wrists up as far as you can go, test them, that way you compare left to right, keep them up. Now, grab them like this, and you go ahead and cross your arms. Don't let the patients do that because it confuses them. Give me a squeeze. I used to have them squeeze fingers until I had a couple of really strong guys hurt my fingers. This will give you a good feel for whether or not they're able to grip equally with all 10 fingers. Okay, squeeze hard, let go, spread your fingers out wide, and don't let me squeeze them together, and that'll test your interossei. Okay, so this is 5, 6, 7, 8, T1. Okay? So super simple, and reflexes. So reflex hammers, if somebody gives you one of those little red testing reflexes is all about consistency. You want to have a consistent stimulus for the rest of your professional career. You want to smack a tendon with the same amount of force every time. You know, Karen and I have done it 20,000 times a piece. If you use one of those little tomahawks and you're gonna eat your Wheaties, you're gonna hit harder than if you're at the end of Friday afternoon and you're gonna hit softer. So get one of these. This is called the Queen Square Hammer. You can get them on eBay for about $4.99. Okay? It's got a little bit of flexibility to it, and just use gravity. Okay? Don't whack with it. Just let gravity fall, because that'll be the same until gravity changes. It'll be the same every time for a gazillion years. Now, the other thing about reflexes is reflexes sometimes can be hard to get, especially if people are tense. And so there's a couple of tricks to getting reflexes. You want to take the tendon that you're trying to get the reflex off. So here we're going to do Nicole's biceps tendon. You want to find the biceps tendon while you're talking to her, while you're feeling her arm to make sure it's nice and loose. When she's distracted and her arm is nice and loose, you got your finger on that tendon, push on it. That'll preload the tendon, it makes it easier to stimulate, and then you hit your thumb, okay? Boom. It's easier to stimulate, she's not tense, you know that she's not tense because you got hold of her arm, and you can feel the reflex in your hand even if you don't see it here. So this is C5, C6 is brachioradialis, not much you can do about that. Then while you've got their elbow here, C7 is tricep. So 5, 6, 7, do it on both sides. And then the sensory you know. 5, 6, 7, 8, T1. Legs are similar. What you want to do is document motion across the joints. So I sit and I say, take this knee, lift it up, and most of my patients don't understand what that means, so you got to mimic it for them. Say, lift your leg up like this, okay? So lift this up, these are hip flexors, then push straight out, this is quads, pull in, hamstrings, feet up towards the ceiling, and usually, so there's two things to test here. There's foot dorsiflexion, and there's extensor hallucis longus. If you just put your hand here and press on them both, you get them both at the same time. And then while you've got them, say press down on the gas. Okay, so that's gas trucking. Okay, reflexes in the legs, pretty straightforward. This is patellar reflex. The ankle reflex is a little harder to get, and so what I usually do is, before I get paralyzed here, wrap your foot around the outside, wrap your hand around the outside of their foot, and just bounce it up and down a little bit. That'll tell you, it does the same thing about distracting in the elbows. You can tell when she's finally loose enough to get a decent reflex, and when she is, and you're talking about her kids or fishing or whatever you want, when she stops paying attention to, oh, this is going to be scary, dorsiflect and smack it, okay? And you get a really nice ankle reflex.